I'm a clinical specialist in child and adolescent mental health services, and I'm also doing my doctoral studies at the University of Warwick, and also have a supervisor at the University of Birmingham. So my supervisors are Dr. Helena Tuomainen and Professor Julie Taylor. My specific research is around autism, intellectual disability, which is also known as a learning disability, and clinical practice in child and adolescent mental health services. It's called a mixed methods multi-phase convergent design, and I'll explain a bit more about what that means as I go through. But one of the things, I guess, which is why I'm here today, is from part of my role in a clinical practice. I can remember a specific time when I was working with one of the members of the team, a therapist, and they had come to clinical supervision quite nervous and I guess perplexed by an assessment they had had. And in the particular assessment, they were saying, I don't know how I'm going to work with this young person. They didn't sit down for the whole assessment. They were pacing across the floor, throwing a ball at the wall. How am I going to do a session when they can't even sit still? And so, just a bit of background on that young person. They had an autism and ADHD diagnosis, and they'd been referred for challenging behaviour, which may have been linked to some anxiety as well. And so I said to the therapist, why don't you take them outside? Because it was in school anyway. I said, maybe in the playground, on the field, and see if that works. Try the sessions out there. Fast forward to 4 weeks later when we had clinical supervision again, and they came in with a big smile on their face and was really happy to share that they took the young person outside and they were trying to teach them about kind of their body's physiological response to stress or to a threat, a perceived threat. And so they had a whistle and they said to the young person, we're going to run around and every time I blow the whistle, you need to freeze. And so they did that with the young person and blew the whistle. And the young person froze and they asked the young person to touch their chest and just to feel kind of what their heart rate was doing. And the young person touched their chest and smiled and said, I get it now. And it was just that simple adaptation that was made to kind of teach them about their body's response, that they were able to get the message of what it meant and how mental health can affect them as an individual. And it's something that I always kind of share just as a bit of a backdrop to actually there are slight adaptations that we can make to psychological therapies to make them more inclusive, but also to allow those to be able to access the service that's needed, which includes neurodivergent individuals. So as we know, neurodivergent individuals, this, could be autism, ADHD, and I would include intellectual disability as well for the purposes of my research. They're 4.5 times more likely to need to access a mental health service because of experienced mental health difficulties. But typically what can happen is when trying to access a service, clinicians can feel less knowledgeable and confident to be able to work with these individuals, which means that there is a barrier to access. That can then affect young people and they end up in crisis a lot sooner. Inpatient admissions are higher, hospital stays are higher, and parents and carers and youth that I've worked with have said it feels like chasing a moving goalpost, or like they can't catch, as the video shows, the chicken. And so for a lot of professionals, they see it as, well, which one comes first, kind of like the chicken or the egg analogy. Is it the autism? Is it the learning disability? Is it mental health? I'm not really sure. So what do I do? And where should they really be best suited and placed within the system? But we do know that early intervention works. And so early intervention for these children and young people is also a priority, and we're keen to look at further. So in study one, the aim for me was to explore triage and assessment protocols alongside clinicians' knowledge, confidence, skills when delivering psychological therapies to autistic youth and those with intellectual disabilities. And so in 2024, a survey went out across 19 NHS trusts in England, and 135 clinicians completed the survey. And some of the findings, this is has been submitted to a journal, so these are some of the early findings, but the full findings I can share with you at a later date. You can also scan the QR code there and you'll get a bit of an animation, which is quite useful, which you can also share with other people, and it helps them to understand a bit more about this area as well. But yeah, some of the earlier findings were that clinicians felt less knowledgeable and confident about delivering psychological therapies to autistic youth and those with intellectual disabilities. And they also felt that they didn't have the necessary skills to deliver psychological therapy to those with intellectual disabilities rather than those with rather than autistic youth. And they believed that they received more training to deliver these therapies to autistic youth than to those with intellectual disabilities. The most used psychological therapy was cognitive behavioral therapy, and the most used adaptation, which is an area of good practice, is making abstract concepts more concrete. There was reported established criteria for accessing mental health services for autistic youth and those with intellectual disabilities. Now, that could be something within a policy manual, or it could be within the actual work manuals that we're given in order to set up our services as well. So maybe that someone needs to have a certain level of intellect to be able to access an early intervention service, or maybe even being able to engage in the way that typical therapies are delivered. But these can also be seen as criteria that is a barrier to accessing the service. So in study 2, one of my aims was to explore the experiences of autistic youth and those with intellectual disability, and another was to understand their needs as well when receiving support from mental health services. So I conducted narrative interviews, totaling 57, with 7 autistic youth, and also some of them had a co-occurring intellectual disability, and also 12 parents and carers. And what we found with this was that for the parents, the children would go down a behaviour pathway instead of a mental health pathway. So from quite early on, even as early as nursery, their children, it would be seen more as challenging behaviour. And so they would go down that route for intervention instead of mental health. There was a lot of sensory needs and challenges that were described during the interviews, and diagnostic overshadowing, which in practice looks like someone saying they wouldn't meet the criteria for a referral to child and adolescent mental health services because they're autistic, or because they have an intellectual disability, or that's not anxiety, that's autism. There was a bit of an emotional stressor for siblings. So siblings were registered as carers because of the family situation and the support that was needed. We also found that there was a lot of system frustrations. So from the onset of mental health difficulties starting, there was difficulties with how to navigate the system. And as we know, as professionals, as clinicians, sometimes we find that quite difficult as well, where to go next and where to signpost to. So parents and carers are also feeling that. There were missed opportunities for our education. So times where maybe it could have been highlighted that there was mental health present, that may have needed some support in that journey as well. So some things that parents would like is practical strategies and support with advocating, as they felt quite exhausted by that, and also needed to support their mental health as well because of the exhaustion of what felt like battling against the system. Um, and some of the outliers, and the reason why it was important for us to mention these is because it shows a different side to the story as well that was given in the narrative. So the importance of dads and their role in accessing services to be included in treatment and planning processes. And there was also good areas of really good practice. So professionals taking a holistic approach to clinical decision making, which is looking at the whole person, not just kind of the mental health or the neurodivergence. And we did have parents share how for them actually it was a straightforward process from the onset of the mental health difficulty all the way to treatment and discharge as well. and some clinicians that had knowledge of their understanding both the neurodivergence, the trauma, and past experiences, which includes being adopted or fostered, because also this can have other complexities that need to be taken into account. But that was also really helpful, as well as physical health needs. Sensory integration was kind of a pattern alongside the more coexisting needs that were there that seemed to be really positive in terms of playing a role in psychological therapy. So that was the parents and carers and their narrative interviews that took place. And I'd just like to share with you a bit about what the children and young people said in their stories. So I delivered this with the children and young people as story stems. And so I told the beginning of the story, and they would finish it using figures that would be animals, stones, feeling stones, Jenga, Playmobil, and they would kind of tell a story and even drawing as well. And so at the start, we did 3 story stems, and the first one, children would share how they felt quite sad, angry, or anxious. They would be in tears and they'd feel like it's not fair. And then as we move through the story stem to number 2, to go and find help from a professional, there was more avoidant tactics. So children would faint, they would go back to sleep, they would want their parents to come with them. They felt like going for help, they were going to see the baddie, and they really struggled with that. We had one child actually share that in the story that the child jumps out the window, and this again shows quite avoidant tactics really, instead of going to seek help. So it just kind of looks at what insight into their experiences of that. The final story stem was, at the moment we're looking at the preliminary findings, so I'm still analysing this data, but the final story stem is showing that children seem to come to a resolution. So after they've found help, they do feel calm, they feel safe, and they know where to go if they need help again. So the final study of my research is around providing a deeper understanding of the current state and future of public mental health services in from the perspective of healthcare, education, and social care services. As we know, we can't have one without the other. We need all of the strands, including external, charitable, and private organisations who work with children and young people who are neurodivergent, and looking at kind of the current state of it, but also the trajectory of where we're going. And this consists of focus groups with these key decision makers. So we've got a final key decision maker focus group tomorrow, and then I'll start analysing those findings. This is just to save the date for next year, where I'll be sharing kind of the findings of study 3, which is the focus groups, and also whatever knowledge I've gained since then as well. And hopefully some of the speakers from today would like to join me again, and new ones as well. So save the date, you can scan the QR code. If not, it'll pop up again if you don't get a chance to do that now. That's fine. And we've got some PPIE that I'm working on, which is patient and public involvement and engagement. And this is a co-design of a framework which Helene, who has joined us today, will be speaking about a bit later on, which we'll be able to share with you in the future as well, hopefully by the end of the year. Some of the things that came up in terms of our PPIE are kind of the referral process. It needs to be a bit more transparent, that you can have mental health difficulties and autism. And, parents have said, oh no, not another parenting course. Techniques that help clinicians to build a relationship with my child, such as being calm and using a calming voice, would be helpful. And the first 2 referrals were rejected straight away, stating that they didn't deal with autism. I was shocked at how they couldn't help us deal with the meltdown he was having after they said they wanted to discuss issues in front of him, which made it worse. So a lot of parents have shared that when they go to appointments, it's quite difficult to share, I guess, how much their young person needs support when they're in the room, because they then have to manage kind of how that felt for the young person to listen to all of that once they leave. So maybe just looking at how appointments are structured would be useful. And also a parent has shared kind of how can CAMHS know what my child needs if they haven't met them. So maybe looking at that, and that's around referral and triage processes as well and assessments. Recommendations include enhancing triage and assessment, improving clinician training, and tailoring therapy approaches for autistic children and young people and children and young people with intellectual disability. Recommendations. Child and adolescent mental health services can use a multidisciplinary approach to allocations. Child and adolescent mental health teams should work in collaboration with schools, health, and the community to ensure that there is joined up working and good practice shared. Clinicians must use autistic children and young people or children and young people with intellectual disabilities interests to engage them in psychological therapies. Clinicians should conduct a holistic assessment of mental health difficulty and needs accounting for autism or intellectual disability. Where a psychological therapy has been chosen, ensure that the appropriate adaptations are in place. Clinicians should include parents or carers in the process of decision making for an intervention and also in closure of a psychological therapy. Key decision makers should review policies, service specifications, and manuals surrounding child and adolescent mental health services to remove language which causes barriers to access. Child and adolescent mental health teams can offer clinicians internal and external continual professional development opportunities. These recommendations will improve the outcomes of autistic children and young people or children and young people with an intellectual disability and also reduce adulthood health disparities. The authors want to thank all NHS trusts who shared the survey and clinicians for taking part in the study, as well as a special thanks to PPI group members who took the time to review the study design, recruitment material and all the survey questions. The study is a part of Naomi Williams' PhD research at the University of Warwick on the Midlands Mental Health and Neuroscience PhD programme. Thank you. So yeah, just some thank you so far from me to all the people that have kind of been on this journey with me for the last 3.5 years.